thank you all, and good morning. Really appreciate all the work that's been done. I want to give a special shout out to my friend and colleague, Dr. David Arsenegas, for allowing us to share that video that he recently recorded in collaboration with the University of Colorado and the Colorado Brain Injury Network. When I had approached him about participating, his response was, well, I could do this again, or you could use this and see how that goes. And when I watched the video, it was really spot on. So that's pretty cool. If you do have any questions about medications or any of the issues that talked about, he is an incredibly responsive, supportive and kind physician. If you also, we have him on, if you will, our medical friend list at the Brain Injury Alliance, so that if you were to encounter a complex medical condition, complex cognitive or rehab condition, we can push questions out to David, and he's willing to help troubleshoot, maybe not every client, but a number of clients a year for the Brain Injury Alliance of Iowa. It's a part of what we get, fortunately, for being a member of the United States Brain Injury Alliance, and then also having that alliance with the International Brain Injury Association, of which David is the current chair. So it goes around. It's great. All right, let's see if I can get my screen to share. How do I share my screen? And anybody on our team can come and just tell me, because this is live, so it is prone to a little bit more technical challenge. Can you see the screen that I have on there yet?
You should still have your little green square at the bottom of your window, Jeff, that says share screen with a green arrow on it. Right on your.
I really wish There is no green square on mine right now, Brandy. All I have is me in the upper right corner and some settings and participants and more at the bottom.
Jeff, I'll go ahead and share your PowerPoint. Just let me know when you need to advance slides.
That'd be great, June. I set it up for that just as a backup, because if you're going to do multi-location technology virtual conference, it's good to have a plan A and a plan B. June, I very much appreciate you doing this. So I'm going to back up. As COVID unfolded, thank you so much, June. As COVID unfolded over the last 2 years, from arguably January of 2019 forward, we've all, whether we like it or not, have surfed a number of waves of this illness, not all of which are really, frankly, the same illness, or that we can be sure yet have the same kinds of outcomes, but that the earliest really severe component of COVID was the Delta strain. And there was a tremendous amount of research that went into Delta and what was going on with Delta as people were getting very sick during that wave and being hospitalized, and there was a shortage of ventilators and really severe illness. We know that the statistics for that were pretty grim from a public health standpoint, but not necessarily from a societal kind of recognition standpoint. Between 1% to 2% of people who were hospitalized died. And now that's a big deal in public health. That's a high mortality rate. But in terms of who we know in our communities, it really is a relatively small group of people, because many of those people had pre-existing conditions, they were elderly, they might not have had the same social networks as others. On the other hand, I do not want to dismiss the fact that many of us, including myself, lost dear friends and colleagues to the COVID pandemic, and that's just a reality. So next slide, please. All right, I just want to say that I've got, and Brain Injury Alliance at this point has no disclosures or conflicts of interest, financial or otherwise. So this is one that we do out of our mission. Thank you. Next. All right, let's look at where we were and where we are. I'm breaking this across two different waves of COVID because the research that I've looked at and we've looked at in the Advisory Council on Brain Injury Task Force on COVID is clear that it distinguishes, most of the research is based on the Delta variant, which is qualitatively different than the Omicron variant. Omicron came along just when we thought we were getting ready to open our support groups and kicked us all in the keister and made us sit on our hands again for another, how many months? Too many months, 6 months plus. And knock on wood, I think that we're recognizing that Iowa and other parts of the country are feeling like Omicron may have done us a favor in terms of moving us closer to herd immunity. And the masking is now not required, although probably a great idea if you want to protect people who are immunocompromised, folks with Down syndrome, and other kinds of genetic or pre-existing conditions. So, be sensitive that you as folks in the brain injury business recognize, because we see it again and again, that having one or more pre-existing occasions of brain injury set one up for a harder outcome for subsequent. And it's the same with long COVID, which we'll find out. But I look back in January 2022 of this year, which is when the Delta virus really had been recognized internationally and here in the United States and in Iowa as having overtaken Delta. And it was now in the 80th to 90th percentile of the causes of COVID. And at that point, there were about 600,000 confirmed cases in Iowa. Forgive my typos. Now, yesterday, I checked the IDPH website again. Actually, I checked the New York Times website. I'm sorry, that's from the New York Times. And in Iowa, there have been a total of 755,000 confirmed cases of Delta, and that includes Delta and Omicron since the beginning of the pandemic. So I'm without the hardest of hard evidence, I'm distinguishing these two periods as we talk about asking the question, how many people are subject to long COVID, chronic COVID, past persistent acquired sequelae of COVID, which we'll talk about. Next slide, please. All right, so there have been a number of different considerations and concerns in the medical community, in the public health community, in the brain injury community about what is going on with people, a large cohort of people who've survived and ideally thrived after COVID. Particularly, there was focus on people who were in the ICU, intensive care unit, with COVID, because the literature is clear about the intensive care unit. People who have intensive care unit stays have a much higher propensity for long-term multi-system challenges after being in the ICU for any cause, as well as long-term psychological and psychiatric changes from being in the ICU. It's a stressful place, and it's a chaotic place. It's a place where people don't get a lot of rest, and it's it's hard. If you've ever been in the ICU or had somebody in the ICU, it's the right place to be. You want people there because the quality of care and the quantity of care is second to none, or it was before our healthcare systems were stretched. But also, we know that people come out with, at the very least, a higher propensity for post-traumatic disorder and other just traumatic and psychosocial and biological changes. So in the New England Journal in June of 2021, this was an article, a perspective article, looking at what really does pretend to be, I wouldn't call it a national health disaster yet, but it's certainly an issue. It's a big wave that my case today is, it's not only just coming, it's here, and we're still deconstructing it as the dust settles a little bit from trying to deal with the acute season of managing COVID. Next slide, please. So what is this thing called? It's called a lot of stuff. COVID-19 is now recognized as a multi-organ, multi-system phenomena with a broad spectrum of manifestations, similar to other historical post-acute and current post-acute viral syndromes described in people who've had other epidemics. There are now increasing reports of persistent and prolonged effects of acute COVID-19. And there, in 1918, we had the globe had a tremendous outburst of flu, very virulent flu, which was referred to as the Spanish flu, and it killed hundreds of millions of people. Much of that went unknown because it wasn't reported in the press, because it was during a world war, and countries did not want to report or draw attention to the fact that they or their militaries were being impacted by this disease. Now, Spain was not in the war at that time, and so they were the first to actually report on this flu virus, and so it became labeled the Spanish flu. It had nothing to do with Spain, but it did shoot worldwide. And it's been unpacked from a DNA standpoint based on graves of people who died with it in the Arctic. So over the last 20 years, paleoepidemiologists have gone and found the nature of that illness and found, tried to map out what its persistence was. However, people who survived the Spanish flu had long, persistent, and prolonged effects. So this is not a new thing with COVID. Having a virulent coronavirus has consequences. And so this is being called things like long haul COVID, which is a little undefined, but it's kind of a catch-all. It's being called past or post-acute sequela of SARS-CoV-2 infection, which is COVID. And that collects and catches both short and long-term symptoms. And then there's been some specific definitions over the last few months about the difference between long COVID, which is symptoms that may persist up to 3 weeks, and then chronic COVID that persist beyond 12 weeks or 84 days. And so much like we heard Dr. Arsenegas talk about with concussion or mild brain injury, sometimes it's best to let the dust settle on what is early long COVID, where people are feeling really frustrated that after 2 weeks or 3 weeks or 4 weeks, they haven't recovered. That's not unusual in COVID, and it happens. And it doesn't mean that people are going to end up with chronic COVID. Long COVID doesn't turn into chronic COVID. Long COVID happens, and often, most often, more than probably 70%, more than 70% of the time, long COVID resolves so that people don't have fundamental long-term consequences from that infection. Next slide, please. All right, you might have this on your screen or cut off, but I scanned the news, and this is in the news. In Iowa, Siouxland woman battles lingering symptoms. Long haulers in Iowa grapple with debilitating symptoms. Long hauler still suffering after a year. Woman still has a 17-month long COVID, wants to serve as a lesson for people to, get their vaccinations. After months of long haul, patients struggle to make ends meet. This is a real deal that people are struggling with across our communities. And it surprises me at some level that we're not hearing more of it in the press. But I think that as, again, the dust settles from the acute phase and consideration of COVID, we're going to hear a lot more about long COVID. And in our community, the brain injury community, we're going to be encountering the neurological, cognitive issues that bring people in. And there are some recommendations that are best practice on how to address this I'm going to share with you today. Next slide. All right, so the World Health Organization has come up with an international case definition of this phenomena. Post-COVID-19 condition occurs in individuals with a history of probable or confirmed infection, usually 3 months from the onset of symptoms, and that lasts for at least 2 months and cannot be explained by an alternative diagnosis. So you can see that 2 months is a little different than the 12 weeks. There's some wiggle room depending on who's making the call. CDC has gone with the 12 weeks. WHO has gone with the 2 months. And I think there'll still be consensus internationally emerging on this. Symptoms may be new onset symptoms, ones that weren't there when they were sick initially with acute COVID, following their initial recovery, or they may be persistent symptoms from the kinds of symptoms that they had in their initial illness. For example, loss of smell or taste. The symptoms, much like other brain injury symptoms, may also fluctuate or relapse over time. They can get better. People can go, all right, I'm out, and then boom, they're back in, and it's a pain. It's a pain. It really is discouraging for people to feel like they've made it out of the woods, and then wake up one day and realize I'm back in the woods. But this definition will likely change because new evidence is emerging on this, and our understanding of what is underlying long COVID, chronic COVID continues to evolve. Good news is that there are now codes that are helping us discern the incidence and prevalence of long or chronic COVID. The ICD-10 now has a code UO 9.9 that is being flagged, and this is now, long COVID has been by the Department of Justice defined as a disability covered under the Americans with Disabilities Act. Next slide. Now, I'm going to just pause for a second and invite anybody who has a question or a comment to put it in the chat box whenever it comes up. You go ahead and chat that in. And I'm going to also ask our team to interrupt me so that if there was a slide or a component that you'd like more focus on, we can pause there. On the other hand, I'm happy to deal with some questions any questions at the end of the presentation. All right, WHO has the list of common symptoms from this phenomena, this chronic and long COVID. They include fatigue, shortness of breath, cognitive dysfunction, and then the catch-all, other symptoms which have an impact on everyday functioning because they're complex. They go across multiple organ systems, multiple components of the body, which we'll take a look at. Next slide, please. All right. As from initial exposure to COVID, you see the little spiky ball in the bottom left, kind of like week 2 and week 3. There are a variety of typical recovery patterns. However, for folks who are going into week 4, week 5, there are conditions that have emerged across 2, 4, 6, 7 known domains. The first one, as is represented by the person in the assistive device, is fatigue or just a general decline in the quality of life. They just can't do what they were doing. Includes muscular weakness and joint pain. There are pulmonary symptoms that can arise, including dyspnea, cough, and an issue of decreased oxygen capacity in people. COVID can affect the lungs. There's the neurological symptoms, which bring the Brain Injury Alliance and our constituents, you all, into the mix, which include both the psychological, neuropsychiatric, and neurostructural potential changes from having had COVID-19, anxiety, depression, sleep disturbances, post-traumatic stress, the cognitive disturbances, which is often referred to as brain fog, headaches, memory loss, These are all initially quite similar to experiences that people have after mild TBI, concussion. And currently, in many practices, the recommendations on how to navigate these are being used those that are in line with recovering from mild TBI. And that's the best we have right now in many places. So, we're referring people to those components, mild exercise to the point where you can tolerate it. Being careful to try to have good sleep hygiene, finding practitioners that are able and willing to look across these domains of physiology to see whether there's something going on. COVID can affect people's circulatory systems, the heart. People can have palpitations and chest pains. They can have blood clotting, thromboembolisms. This can cause their blood viscosity to change and change their propensity for stroke. Kidneys are apparently much more at risk than other organ systems, not all, but they have the ACE2 receptor sites that those COVID spikes love to jump into. And so there's a group of people that end up having differences in their ability of kidneys to process the waste. And as we know, when you have your kidneys offline or wonky, your whole blood chemistry gets wonky, and that affects that can affect your cognition. And then more recently, it's been seen the consistency and documented that there are people who have hair loss after COVID, which suggests that it affects some of the rapid growing, rapid reproducing cells in the body. All right, next slide, please. So other symptoms that are general that are being reported include the ones that the WHO had, but also include others. And again, as before, fatigue, brain fog, this loss of smell and taste, shortness of breath, cough, persistent cough. Now joint pains come up, and that suggests perhaps some kind of immunological triggering, brings in the rheumatologist. Chest pain brings in the pulmonary thoracic people. Sleep issues brings in the sleep experts. Anxiety, there's your psychiatry connection. Gut problems, gastroenterologists have can get seen as a first sign, medical profession for long COVID. Fever, durable fever, muscle pain, depression, headache, rapid heartbeat. There's a lot of specialties that end up being first point of contact for people right now with long COVID. And there are not enough providers that have an integrated long COVID team in which the first person who sees somebody is looking at them holistically to try to decide which specialty or how many specialties to get involved, because that gets to be a very complex medical landscape, as we know, hard for anybody to navigate, let alone the healthcare system, let alone right now after it's been whomped. Next slide, please. All right, there are rarer symptoms that have emerged that are actually much more concerning to people. There are durable inflammations of the heart muscle, lung-related issues, just a decrease in lung capacity, and it's durable decrease. There are long-term kidney problems that people have. We talked about hair loss. Folks have skin rashes that seem to be associated and are well documented as being related to having had COVID. And then this definite and regular, and it seems frequent report that problems with concentration and memory for many people are durable and disconcerting and life-changing and upsetting. It can affect employment, it can affect relationships, it can affect finances. As we know, having cognitive challenges is a game changer. Next slide, please. So as I looked through the literature over the last couple of years, I saw something that had been in the press, or actually in the literature, the healthcare literature, for long enough that if there was any need to have a retraction to it, I'm now skeptical, like everybody else is, of early reports of this correlating with that, or somebody has some revolutionary report. I like to sit on those before talking about them to see whether they've been replicated. But this is a systematic review done by Groff in the Journal of the American Medical Association, where they looked at 2,100 eligible studies that had looked at long COVID just over the previous year from 2021. And they found that methodologically, there were 57 studies that they felt were really tight, robust, that they could use to discern what's up with long COVID. Now, of those 57 eligible studies, they ended up with 250,000 patients. So that's a big N, which is good. However, there were 79% that were in, and we'll talk about that in a second. 79% were inpatient with 1 to 6 month follow-ups. Interestingly, I think highly interestingly, there were no major differences in long COVID when looking at high income versus low income countries, or even most interestingly, amongst those people that had hospitalization rates versus those who didn't get hospitalized. And these periods of time in the graph down to the bottom left, right at about the 50th percentile, show that across those domains of people who had a short-term illness, an intermediate time period illness, or a long-term struggle being hospitalized with COVID, their rates were around 50% prevalence for long-term, at 6 months, long-term symptoms that were durable. So again, short-term illness, intermediate illness, long-term, which we might call in another way, people who had a mild case of COVID, a moderate case of COVID, and a severe case of COVID have had in this study of studies up to a 50% rate of prevalence. Next slide, please. So again, the symptoms that were being reported by that group of 250,000 people included, well, any symptom first. Chest imaging abnormalities were at 62%, just a general functional impairment, a body, just being wiped out, 44% fatigue, general anxiety disorder, and then 24% people difficulty concentrating, some kind of cognitive income at almost 25% with a range of 20 to 26. Next slide, please. So then just to take another look, there was another study that I looked at, again, trying to focus in on that time frame of Delta, which has a ton of people in Iowa that had it, that the 1-year outcomes in hospitalized survivors with COVID-19 were in the same kind of zone, fatigue and weakness, both at 6 months and at 12 months, 52% and 40%. I wish I had my pointer, I could point to it. I've got it on my screen, but I don't think it shows on your screen. Sleep problems decreased, fortunately, between 6 and 12 months from 27 to 17%. Smell disorder, thank you. Smell disorder was durable across that time. Anxiety and depression seemed to increase. CT chest scans at 6 months, people had 100% visualization, which after 12 months, fortunately, about 60% of those folks resolved. Gas exchange in the lungs, meaning your ability to utilize oxygen, and then ongoing shortness of breath. So these are, again, another study, an independent study, only using 1,276 people, British Journal, that again backs up that that this is something that's actually happening. Next slide. All right. Again, a look at what the prolonged symptoms at 6 months were most common in outpatient COVID patients by age. And we see that even though we've known, we thought at the time, and it was well publicized that that early wave of Delta infection was more severe and more concerning for our elderly, and that young people had much less to worry about. Yeah, it might not have been exactly true, because we're seeing that young people still had close to a 30% of prolonged symptoms. Again, even if that's mild, moderate, or severe degree of acute infection. And it goes up, obviously, as through the age groups. And again, the hypothesis is that our immune systems work differently at different seasons of our lives. But again, that's just a hypothesis. So age 40 to 64, closer, right on to 30%, 18 to 39, more like what, 27, 28%. But over 65, people, our seniors, if you will, who ended up with COVID, they have over 40%, typically long-term challenges or sequelae after 6 months after COVID-19. And that's again, focusing on those who were in the Delta wave. Next. And then what were they? The post-COVID symptoms at 1 year in these groups. Any symptoms people had, of the ones who had symptoms, there were bunches, but fatigue and weakness, sleep disorder, muscle joint pain, cognitive, now we see at 29% in this study by Lombardo, and respiratory problems at 27%. Again, for us being approached by people who the cognitive problems are the most concerning, what I'm trying to portray here is that let's not just use only one lens of, we want to focus on helping remediate, ameliorate, adapt to, or accommodate cognitive symptoms, but this really is a potentially multi-system issue. And I think that we're going to want to make sure that there's not some other systemic issue driving the cognitive symptoms. There may or may not be, but we probably can't address the cognitive symptoms in a vacuum. Have an interdisciplinary team that will settle on, yes, it's time, as Dr. Arsenegas said, after the dust settles, to engage in some cognitive rehabilitation. That can work. But I think also, as we heard from Arsenegas, if it's not working, it's probably best not to keep hammering on it. Again, this is complicated stuff, but that's brain injury. I was once told by an ICU nurse at the University of Iowa Hospitals and Clinics who'd been there for 15, 20 years. And she said, we get a lot of new nursing staff in here, and we find that people either hate working with people with cognitive issues because it's so complicated, or they love it because they've got a Sherlock Holmes kind of orientation and they want to try to keep digging to find ways to help people get better. Next slide, please. Okay, here's one of the problems with the data that we've looked at. We're only looking at people who've been selected with severe or hospitalized illness, or we haven't had any control groups. So those are hard to obtain. It's hard to be infecting people with COVID and trying to have control groups as we go. And frankly, I don't know about you, but I don't hear as much anecdotally from my friends and neighbors. I mean, I know more people than most because I work in with the Brain Injury Alliance. So we get an inordinately higher number of calls, and I get sought out, as do our staff. But just on the street, I don't think we hear as much anecdotally from our friends and neighbors about these levels of rates. And it's kind of a head scratcher. I'm the last person who wants to create any kind of drama about a new condition that adds to the number of people in Iowa with long-term disability from brain injury. Holy cow, we've already got 100,000. And if we add another 100,000, it's, I guess we have to be prepared for that. And that's what we're trying to do with the legislature right now, is give them a heads up that there is a high possibility that this wave is coming. Next slide, please. So to address that issue of selection bias, there is evidence that this is a real deal. If we look at functional impairment in healthy healthcare workers, at least 2 months out from mild COVID symptoms, and we look at the difference between people who tested positive and for COVID, we find that both groups have had some impact from the COVID pandemic. Whether they had COVID or not, we don't know, especially the seronegative. It could have been a false negative. On the other hand, it could just be the stress related for all of us. Mental health stresses, changes in our physical interactions with people, isolation, just ongoing stress about caring for friends and relatives and self. Those have functional impairment potential. But the difference here is the darker bars are the people who have tested positive for COVID compared to those who did not. And we do see that the participants with functional impairments are significantly higher than those in work life, social life, and home life, with mild, moderate, and in this case, they don't say severe, but they say marked experiences in the acute phase. So it's likely not all data bias, where we're just looking at people with the worst of the worst. This is looking at people in general. So we know that COVID's had an impact on the general population across many domains and functional domains. We also know that those who have had positive tests for COVID have a significantly higher risk of functional impairments. Next slide, please. So many people I've seen ask, and I've been asked, well, what about the flu? People have had flu with lingering patients. People have had the flu for years with lingering symptoms. Why is COVID different than the flu? Well, yeah, COVID's different because these symptoms are substantially higher than what we've had over the last 4 or 5 decades. It's not really clear whether they're higher than those in the 1918 Spanish flu pandemic. For those who are followers of Oliver Sacks, which some of us in the brain injury community know was a prolific neurologist and writer. He wrote a number of books, but he was also the basis for the movie that Robin Williams did called Awakenings. And if you haven't seen that movie, I encourage you to watch it, because it's a historically accurate portrayal of people who had been institutionalized in a state of cognitive locked-in syndrome. And there was a clear and high correlation of the number of people who had also experienced the Spanish flu. So each of the pandemics that we have documented that came out of the coronavirus and like viruses have had documentation of significant neurological impact. So this is not new. COVID's not like this new outlier. And in that movie Awakenings, without giving you the spoilers, there are some revolutionary changes that Dr. Sacks was able to bring to some of his patients. And there were some bittersweet outcomes, some very sweet, some very bitter. We're not sure where COVID's going, but I can tell you for sure, the literature's clear that COVID has a substantially higher set of persistent negative outcomes for people's lives than did the flus that we've been getting, well, some of us have been having the opportunity to get vaccinated for most of our lives. Next slide, please. Okay. This one is that going back to that study by Groff, just showing both the neurological orders, the frequency of disorders, plus the upper and lower levels of neurologic disorders: headache, taste disorder, smell disorder, cognitive impairment, memory deficits and difficulty concentrating in that order of frequency. 20% of difficulty concentrating from that group of 250,000 people who were studied. About 18% of people have who report memory deficits. Looks like 17% report cognitive impairments. And headache is in the 12 to 15%. On the mental health side, on the right-hand side of this graph, PTSD, depression, sleep disorder is no small deal. And trying to sort sleep disorder out from daytime cognitive changes is a bugaboo. And so again, engaging folks with sleep hygiene and sleep opportunities, not benzodiazepines, as Dr. Arsenegas suggested, because those plus others actually perpetuate or accentuate cognitive difficulties. And then general anxiety disorder, pretty high in post-acute sequelae of COVID, PASC, or chronic COVID folks. 20 to, that looks like 25% is the midline, with a range of 18 to 42%. These are pretty solid data. Next. So what's going on? I mean, how does COVID do this? Is there one way? Are there multiple ways for different people? Things going on? And the answer is we don't know yet. We're still working that out. The medical community is still researching that intensively. There is the knowledge that COVID crosses the blood-brain barrier and that the virus itself does impact and directly infect tissues in the brain. That can and does happen. There's also a clear understanding that COVID triggers in many people an autoimmune response, whereas it's not what's impacting the brain, but that there is some part of the body that is immunologically compromised. Could be the gut, could be another organ system, and that is flooding in to an attack on the brain. And then there's this distal inflammation, that there can be an inflammatory response anywhere in the body, which sets up a chemical cascade that travels across the brain too. So what I've heard it described is, if you've got an inflammation somewhere, you've got an inflamed brain. It's being grumpy and having challenges in your cognition go along with having any persistent inflammation anywhere in your body. So there are quite a number of areas for considering what this virus and other viruses do that might be setting us up for both the cognitive changes as well as those multi-organ changes. But this is just focusing on the cognitive. Thank you, June. Next slide, please. All right, so what else is complicating this? As with brain injury, chronic or long COVID happens in human beings, and we are a complex geographic and genetic and cultural landscape. Before COVID, the recognition, and this was in the CDC's MMRW in July of 2020, is that across the country, the median US county prevalence for any underlying medical condition was already 47%. So let's keep in mind that about half the people who encountered COVID-19 have it plus some other underlying medical condition. So, trying to tease that out and or determine what the relationship is between the viral infection and the synergy that it might be having on an underlying medical condition is no less difficult than those of us in the brain injury business or people with lived experience who have multi-occurring challenges. When we know from the research that the three biggest risks after having had traumatic brain injury are substance abuse, depression, and then unemployment. Now, unemployment's not an underlying medical condition, but it certainly has a connection to people's psychological and financial health. So the next slide, please. So what to do? I mean, how to navigate this long COVID issue? How is there still no definitive single biological or biometric diagnostic test? You can't get a test for long COVID. It's discerned based on reported symptoms with a history of known COVID infection, a seropositive test or a report of somebody who's had the home testing positive. And frankly, I think that just having people report that they had a upper respiratory infection during one of those waves of COVID makes some sense to take into account that people likely had a COVID or a viral infection that has a connection with what they're struggling with in having long chronic or COVID or past, depending on what term you want to use. Next slide, please. So in Iowa, if we go back to the math, we'll see that in January 2022, there were at that time about 600,000 confirmed cases. The literature is very robust in suggesting and in indicating that 10 to 30% of people who had Delta, the Delta variant of COVID, of which we can be pretty clear that about 600,000 of those had Delta or the pre-existing COVID wave, which again, I haven't teased out, but we're looking at an additional 59,000 to 178,000 Iowans with long-term functional changes, functional impacts from long chronic COVID. Actually, in this case, chronic COVID, not long, chronic COVID. And in there, we see that 10 to 30% of that group have cognitive issues, which can and which will bring people oftentimes into our world first and or downstream. Now, yesterday, with 755 confirmed cases, both Delta plus Omicron, that's up to 226,000 people with long-term issues. We haven't sorted out yet if Omicron has a different type of outcome for long-term COVID. The initial reports are that yes, there are people, many people, not quite sure how many, but many people who had mild, moderate, or severe Omicron-related illness, and they are experiencing COVID symptoms. Again, I'm just trying to focus on the known literature that was more related to that Delta wave. It's a complicated, and God help us. I am praying that our waves are over for these variants. Next slide, please. So what to do? This is one that has been in place for many, many years, and it's well established. It takes an average of 17 years for medical evidence-based research to penetrate across healthcare provision in the US, and sometimes longer outside the US, 17 years. And it's one of the reasons that the Brain Injury Alliance of Iowa and the USBIA and other groups like it exist, is to be able to get rapid, relevant, and reliable information into people's hands to try to jumpstart issues and systems change, and actually just individual capacity to advocate for selves in this area. Brain injury providers and the Brain Injury Alliance of Iowa, we can tend to focus on the neurological and neurobehavioral, the cognitive impacts of brain injury. But we have to remember that there has been and continues to be an increase in recognition and our training in comorbidities. I mean, we've recognized that in our shop, and I'm sure you have too. There's trauma, there is mental health, there is substance abuse, or the kind of the big three that we've been focused on. But now there are even more medical complexities for us to learn about. And remembering that the patients, the clients in our shop, but if you're in the medical world, We call them patients. And if we're in the survivor world or family world that I live in, we and our loved ones are much, much more than our cognitive challenges, than our brain injuries. There's a lot of stuff going on. Long COVID's wrapped up in a degree of complexity that there is tremendous research being focused on this. And we'll continue to update you. And if you want more current updates, you can be looking at our website because we've been posting those regularly. Our staff person, Allie Martin, resource facilitator, neuroresource facilitator, is a member of our USDA long-term COVID task force that meets monthly. And we share information, we share fact sheets, we share best practices. And so we'll keep those documents and what we know about it in kind of the one-pager reviews so that you can check in there whether you're a provider or a person with a brain injury or a family member. We're going to have to be aware that treatment, rehabilitation, adaptation, and accommodations for this phenomena, for long COVID, for chronic COVID, will need to be customized to the person, as we always have had to do with brain injury, depending on their unique manifestations of symptoms. But try to keep our blinders wide. My mother used to claim that she was not closed-minded about certain things because I'd call her closed-minded about an issue. And she'd say, I'm not closed-minded, Jeffrey. I'm just narrow-minded. I think it's easy for us in the brain injury world to be narrow-minded based on the stuff we read, which is about brain injury. But to keep our blinders off and to keep them open enough to remember we have to read about other literature so that we can oftentimes refer people out to make sure that there's not some kind of co-commitment issue going on. Next slide, please. So we have some COVID clinics that have emerged in Iowa and elsewhere. You can find those listed at our BIA Iowa site. And if you give a call to our 855-444-6443 number, which I'm going to list, our nurse staff can provide you a list of those. There's a curve up and down with our COVID clinics in Iowa. Some focus pretty much really well on the neurological outcomes of COVID. Others have taken an approach where they start with a lung specialist, because people who have lung problems from COVID, of the symptoms, are the highest, and they want to be able to rule that out first. But the pulmonary specialist that has seen people in these COVID clinics is one who's a generalist by nature. They may have a specialty in pulmonology, but they're not looking at the patient from a pulmonologist lens. They're looking from a holistic lens to try to determine which specialty may be the best one to start in, trying to tease out which organ system may have the impacts and how to bring a team together to best respond to somebody's issues. So we recommend that folks with chronic COVID check with your healthcare provider or the Brain Injury Alliance for a list of options, as well as our current fact sheets. And we do have some for home-based recovery supports, and those change. Those get updated as time goes by, as did our concussion protocols, as does much of the recommendation about brain injury, as Dr. Arsenegas talked about, the different levels of practice standards, the different evidence bases. But we're at www.biaia.org, and there's a COVID section. If you feel you've got symptoms that are interfering with your life, seek COVID savvy medical care. And if you're not sure how to get there, how to pay for it, or doesn't get qualified with all those components, our resource facilitation staff are on deck to help point people to clinics with best practices, to help think through how to get transportation to get there, to help get obstacles out of the way. When we're doing our job well, our nurse staff are helping identify obstacles, make the connections to get around and through them. We don't have pixie dust, we don't have magic wands, but we do some pretty damn good work. We have a staff that is leading the country in many ways in these areas. And then the current best practice, I'll just tell you that I've read consistently, is to engage a team of healthcare professionals who look at the issue as holistically as possible. And wouldn't that be great for all of us if we could have, a team of people? But this is something that crosses pulmonary, cardiological, I can't say that, nephrology, kidney issues, neurological, mental health. So depending on what is going on, some or all of those need to be addressed. Next slide, please. So what's next in Iowa? Well, the Iowa Advisory Council on Brain Injury has made a commitment to producing recommendations for the Iowa Department of Public Health to post for Iowans with long and chronic COVID. IDPH doesn't have any that I'm aware of right now, but we're pushing them as a advisory council, governor's appointed advisory council. I'm not, I'm ex officio. I just kind of show up. I was once on the council and now I'm a non-voting member that they let show up and just annoy them. But I'm co-chair of the council's long COVID task force. We will continue monitoring promising best and evidence-based practices for responding to this issue. And you can call us, I hope I got the right phone number there, at 855-444-6443, and or email us at info@biai.org or come to our website to get more ongoing information about this issue and other issues related to brain injury. I think there's only one more slide because I'm getting the heads up that I have to finish up. There it is. Thank you. I'm Jeff Lauer. I have the great good fortune to work with a tremendous team of volunteers, of paid staff, and to have a job that demands and lets me use skills in my graduate experience, which was health communications, in digging into the literature to try to find and help translate medical literature so that it's available to our constituents, regardless of educational level, and then to have excellent staff help translate that so that people have knowledge and capacity to make choices if they want to. Are there questions?
There are some questions. Go ahead, Courtney.
Oh, I'm sorry. Hi, Jeff. This is Courtney. Looks like we have a couple minutes for questions. I'll just start with the first one in the chat box. Have there been studies done yet that indicate cognitive decline on neuropsychological exams after having COVID?
It's an that's a great question. I'm pausing because I'm sorting out the great deal of literature that I've seen on the relationship between brain injury, acquired or traumatic, and early onset cognitive decline, which has a high evidence base. People with brain injury, especially the more you get, the earlier the onset appears to be for mild cognitive impairment and Alzheimer's-like impairment. And it is believed that the inflammatory component of brain injury, just getting your head hit in a traumatic injury or an acquired brain injury, that inflammation opens the door to a chemical cascade that lays down what are called the tau proteins that are similar to those in Alzheimer's disease. And the reason this is kind of a big deal is there's a new drug out called Aduhelm that is not yet recommended cognitive decline from brain injury, but has a great deal of potential to be used for folks who have early onset dementia. And it's been shown both medically, chemically, and clinically to reverse cognitive decline at a tremendous level. So with COVID, I don't think, the answer is no. I don't think we have enough time yet since the pandemic started to really get that teased out. We're going to have to wait and see over months and years whether there's a correlation between having tested seropositive for COVID and having increased risk for that.
Thank you. Let's do one more, Jeff. In your review of the literature, did you find any studies that link the loss of smell or olfactory bulb inflammation and related inflammation of the prefrontal cortex or executive dysfunction?
Yes, and yes, but not just. So different people had different scanning within the first 6 months when MRI technology, fMRI technology, and SPECT scanning in the experimental zone was done for people with COVID-related long-term sequelae that had neurological impact. There were changes to the brain. I don't remember any specific that dealt with inflammation of the olfactory bulb, but there were a number of areas of the brain that were flagged that had visible changes. Now, again, the visible changes are correlational, potentially with behavior, but they weren't felt to be causal. The good news was that after 6 months on follow-up, the vast majority of people no longer had imageable changes in their brain. The bad news from that is not all of them had resolution of symptoms, just because the visible symptoms went away. And which speaks to the fact that imaging doesn't always well indicate durable cognitive changes. So yes, there are changes in the brain. I don't think inflammation was the flag. It had to do with the ability of the brain to either process glucose and or I'm trying to remember which chemicals. I'm sorry, I don't. The answer is yes, there were visible brain changes, both in hippocampus, frontal lobes, and then for different people, just in different parts of the brain. It wasn't specific. It wasn't like COVID sought out one area in the brain, although the route in is pretty clear. With the upper respiratory component of COVID and access to the olfactory nerve, that is absolutely the canary in the coal mine, so to speak, for having a neurological impact of COVID. There's still a question about how far and how fast the virus could travel up and through that nerve. As we know, viruses do travel on nerves. Shingles, for example, the chickenpox virus travels down nerves, and COVID seems to have the same pathway. But whether that was the entryway or whether it was through the bloodstream is yet to be determined.
Thank you, Jeff. Thank you for a wonderful presentation, for answering some of those questions. It looks like we have a handful of some other really great questions as well. We'll make sure to get answers to those for folks.